morning, everybody. Our food is running just a little bit late, so when it does come in, I'll just ask people to kind of slowly go back and not have a mad rush. But as it comes in, certainly feel free to go back and grab some food. We'll try and not have a huge line, so we'll just be a little bit orderly. Awesome. Excited to hear. Today we have a PGY4, so Lillia is going to teach us a little bit about the pathophysiology of obesity. So with that, I give it to you, Lillia.
Good morning, everyone. Thanks for your attention. Sounds like there's someone here. I think that should sound better for everyone who's not here. Good morning, everyone. Thank you for coming and listening to my talk this morning, where I just want to review some of the pathophysiology of obesity and its impact on the musculoskeletal system. I want to start by giving a shout out to Dylan. It turns out trying to find a picture of Dylan smiling is pretty difficult, but you can find him smiling when he's out in the river. He's going to be doing his trauma fellowship next year in Mississippi, which is centered in the most obese part of the country. So it's surrounded by 3 of the most obese states in the nation. So while in Utah we may not deal with obesity to the same extent, it certainly is a growing epidemiologic concern in the United States. Obesity affects 1/3 of adults in the United States and nearly 1 in 5 children. The scope of the problem is projected to increase, with almost half of adults being considered obese in the next 10 years at current rates. You might be thinking, yes, we know obesity contributes to the development of arthritis. Obviously, carrying more weight on your frame wears out the cartilage and connective tissues. How are you possibly going to spend an hour talking about this? Well, one of my interests throughout residency and training has been to more deeply understand the musculoskeletal physiology and the role that other organ systems, including the nervous system and the endocrine systems, have on contribute to orthopedic pathology. And this curiosity is also driven in part due to some personal experiences during residency. One of the cases that really sticks with me is this case of this obese woman. She has a BMI 51, who essentially had a ground level fall at home. This was her second injury in a short period of time, so she'd already had a pre-tibial laceration and then presents to our emergency department with this transsyndesmotic ankle fracture dislocation. The severity of this fracture from such a low energy mechanism not only surprised me, but the challenge of managing her soft tissues became really the primary concern. You know, managing the bony injury was pretty straightforward, but the lacerations that accompanied this injury really challenged me, and I struggled to close this laceration over the medial side of her ankle, which left me worrying for months and following her, in clinic, worried that she was going to develop an infection that would threaten her leg. So part of this, my goal is here today, is to convince you that similar to some of the other comorbidities that we actively consider and manage, the state of obesity is not just a passive risk factor, but also an active contributor to the pathophysiologic state, which leads to worse outcomes. And if you're at all interested in biology like me, perhaps this will inspire a question worth investigating to help us better understand the effects of obesity and how to manage them. Just to orient you a little bit to my plan this morning, I'm going to start with some of the outcomes associated with obesity before moving into the mechanisms underlying them, and then returning to what interventions we have available to us to affect these outcomes. So obesity is defined as having a BMI over 30, and morbid obesity is considered a BMI over 40. Obesity is associated with diseases of many organ systems, especially the cardiovascular endocrine systems, as well as multiple malignancies. Generally, we consider obesity to be the result of an imbalance between caloric intake and energy expenditure. However, there are complex genetic and behavioral interactions that contribute to the development of obesity. Parental BMI is associated with the development of obesity in children, and twin studies of separated or adopted twins find that there's at least a 50% heritable contribution to the development of obesity. The musculoskeletal effects of obesity are far-reaching. affecting every subspecialty, but I will focus on just a few general groups of pathology here. So starting with osteoarthritis, increasing BMI has been identified as a known risk factor for knee osteoarthritis and to a lesser degree, hip and ankle arthritis. Patients who are obese are more likely to have symptomatic arthritis at an earlier age and more rapid progression of their disease, as well as an earlier time of arthroplasty. This is attributed to increased contact forces, especially within the medial compartment of the knee, as well as changes in alignment of the lower extremity during gait, which results in a varus alignment at the knee, a greater knee adduction angle and moment, and increased load transmission through the medial compartment. A 2019 systematic review found that morbidly obese patients had higher overall complications following knee arthroplasty. This included prosthetic joint infection, superficial infections, or wound healing complications. They also have increased rates of aseptic loosening based on a subset of the papers included in this review that reported on those complications regarding loosening and wear. In line with these findings, a recent 2022 report from the National Inpatient Sample Database found that morbidly obese patients undergoing revision total hip arthroplasty had higher rates of postoperative anemia, hematoma, wound dehiscence, and postoperative infections. Between the foot and ankle and sports literature, there's also evidence for higher rates of soft tissue pathology in obese patients.
What's that?
An observational study
I have to go. I have a last virtual interview.
BMI found that diagnosis of plantar fasciitis, tendonitis, and osteoarthritis of the foot or ankle were significantly increased in overweight or obese patients.
The sound is muted.
which we previously reviewed, are negatively impacted by leptin, its counterpart. Adiponectin also mediates extracellular calcium influx into cells, thereby increasing muscle recruitment and muscle force. On the other hand, leptin has been shown to negatively impact muscle composition, leading to lower levels of skeletal muscle mass. This relationship between leptin and adiponectin is more important because sarcopenia is becoming increasingly recognized as a silent contributor to musculoskeletal pathology in aging and obese patients. Sarcopenia is the loss of skeletal muscle mass or strength. It is associated with increased falls, disability, and higher rates of fracture. And while you might think correctly that sarcopenia is just the natural history of what happens to junior residents on night float, it is increasingly common in our geriatric patients, with an estimated prevalence of 10 to 40% in community dwelling adults. Skeletal mass normally declines with age, and this is attributed to an increasing catabolic state in geriatric patients, with 80-year-olds having lost about 40% of their skeletal muscle mass compared to their age at 20. Obesity, on the other hand, tends to increase with age, and the combination of these two is referred to as sarcopenic obesity. This is defined by having 2 standard deviations less of muscle mass index when compared to 20 and 30-year-old reference individuals for the same, as well as having body fat over the 60th percentile for patients of the same gender and age. While this state is more common in geriatric patients, it can also be seen in young adults and children. The imbalance between muscle strength and increased demand of mobility with obesity results in a mismatch between energy available that's required for expenditure and the demand, leading to functional impairments, including decreased gait speed, difficulty rising from a seated position, and difficulty with ascending stairs. The same biologic features seen in obesity are associated with sarcopenia. Namely, there's increased inflammation, reactive oxygen, species production, as well as higher rates of endocrinopathies, specifically the development of insulin resistance. Obesity results in fat deposition within muscle tissue, which combined with declines in protein synthesis and mitochondrial function leads to decreased muscle strength. Abdominal fat is notorious for the production of high levels of inflammatory cytokines like we discussed previously, and this further contributes to muscle atrophy and sarcopenia. In addition, as patients age, they have lower levels of anabolic hormones, including especially testosterone, which only further exacerbates this state. The anabolic IGF-1 axis declines with aging even further, and this is a cyclic process that has been shown to increase obesity and result in decreases in muscle mass. Finally, insulin resistance associated with obesity impairs the anabolic role of insulin on skeletal muscle as well as impairing the recruitment of glucose transporters to the cell membrane. One of the challenges in further understanding the role of sarcopenia on the clinical outcomes is in part because it's difficult to diagnose. It requires a reliable baseline measurement of whole body muscle mass. And this can be done through skin fold testing, bioelectric impedance analysis, hydrostatic or air displacement, or a DEXA scan, which we don't always have available to us. The good news is that grip strength has been shown to be a reliable surrogate for whole body strength. And this can be utilized for the diagnosis of sarcopenia for patients in clinic or in the hospital, where a grip strength of less than 16 kilograms in women is the threshold for sarcopenia. While this hand grip strength has previously been identified as a positive predictor of good outcomes following hip fracture and the ability to perform ADLs for patients who are above the 16 kilogram cutoff, this recent study sought to compare the combined effect of obesity and sarcopenia on outcomes following hip fractures in women. They prospectively evaluated women with hip fractures who were able to participate in intensive rehab following their injury, including which consisted of 3 hours of physical therapy like you would see in an inpatient rehab setting. These patients also had to be able to tolerate weight bearing on their operative extremity to be included in this study. They had 2 notable findings. One was that, again, hand grip strength was a reliable surrogate for sarcopenia when compared to DEXA scans evaluating patients' body composition. And second, sarcopenia as measured by hand grip strength was associated more with functional status following hip fracture in geriatric women than their fat mass or their BMI. Decreased muscle mass with age is also associated with the loss of some of the beneficial qualities of skeletal muscle. Namely, muscle weakness is associated with a decline in bone mineral density, which has been termed osteosarcopenia in the literature. Biomechanical studies also show that quadriceps weakness reduces shock attenuation in the knee, potentially contributing to greater force transmission and part of the mechanism for accelerated osteoarthritis. Lower muscle mass is also correlated with cartilage loss over 2 years in patients without osteoarthritis. And finally, loss of muscle mass is also associated with just functional declines that we observe in patients. So now that I've kind of summarized the negative effects of obesity and sarcopenia on various aspects of the musculoskeletal system, then we're left with asking, is there anything we can do to mitigate these negative consequences? The most obvious answer for rapid and effective weight loss is bariatric surgery, especially for patients with morbid obesity, those with a BMI over 40, who are at the highest risk for adverse outcomes. Lap band is a restrictive but adjustable procedure that decreases the total volume of the stomach, which is becoming less common due to some complications, leading more often the procedures of gastric sleeve or Roux-en-Y bypass, which is notably malabsorptive. All three of these procedures have been shown to change the neurohormonal signals that drive behavioral eating and reverse the metabolic and cardiovascular consequences of obesity. However, they are associated with mild to moderate decreases in bone mineral density, up to about 14% of which occurs in the first year. This has been theorized to be related potentially to just a decreased physiologic load on the skeleton, but it's also potentially related to the changes in the neurohormonal axis that occurs with bariatric surgery. As established earlier, BMI is associated with increased bone mineral density. So for these patients, as seen up in the figure in the upper right, the change in their T-scores may not be quite as deleterious as someone who's already starting with osteoporosis, as evidenced by T-score changes that are still above age-matched averages. On the other hand, changes to bone quality are observed for years following gastric bypass, including changes in the microarchitecture on quantitative CT, decreased cortical thickness, as well as reduced projected strength on finite element analysis, potentially contributing to increased risk for hip fracture. So just about a year ago, this RCT from Australia was published in JAMA, which looked at patients who underwent total knee arthroplasty following a lap band procedure. Patients were either assigned to undergo total knee arthroplasty versus undergoing a lap band procedure followed by their knee replacement a year later, or once they reached a 20% weight reduction, whichever came first. In this study, they were able to randomize 82 patients. Of those who randomized to first having a lap band procedure, nearly 30% of them ultimately declined total knee arthroplasty after a year because they had such a significant improvement in their symptoms. The average weight loss with this intervention was only 16 kilograms. Now, they did find a reduction in the number of complications in patients who underwent a lap band procedure prior to total knee arthroplasty. However, the effect is a little bit overrepresented in this Kaplan-Meier curve because they include patients who declined surgery in their analysis. Moving on to medical weight loss, this is becoming more utilized over recent years. Most anti-obesity medications, including stimulants, have an effect somewhere between 5 to 12% of weight loss. This medication, semaglutide, is a once-weekly GLP-1 agonist, which has anti-glycemic effects, making it useful for the management of type 2 diabetes previously. However, it was just under 2 years ago that the FDA actually approved this medication for medical weight loss. And in clinical trials, patients lost an average of 12% body weight over 3 months. In follow-up retrospective studies, total weight loss was similar but was seen over a longer period of time. So it took about twice as long for patients to lose the same amount of weight. GLP-1 activation has, in some animal studies, been found to increase RUNX2, ALP, and type 1 collagen production, leading to increased osteoblast stimulation. This GLP pathway also stimulates Wnt signaling, which potentially upregulates osteoblast differentiation from mesenchymal stem cells and promoting more activity. While human studies included in this systematic review were equivocal on the question of bone mass for patients taking this medication, animal studies consistently found higher bone mineral density in mice or rats exposed to semaglutide. These findings are reassuring that this medication may be able to provide weight loss benefits for patients without the negative effects on bone density. So I've spoken a little quickly, so I'm already at my summary slide, but just to highlight a few takeaway points. Obesity is a growing problem in our patients. It's associated with higher rates of tendinopathy, arthritis, and knee pain, as well as complications following surgery. Higher bone mineral density, not consistently protective against fracture, and patients with high BMI may actually have higher rates of non-hip fractures. Adipose tissue is inflammatory, and this is bad for bone as well as soft tissue and muscle mass. And leptin, which is produced by fat cells, is able to directly modify skeletal and chondral physiology, making it a potential target for future studies. Increasingly, we're recognizing the role of low muscle mass in the setting of obesity and its contribution to poor outcomes after orthopedic procedures, again, giving us a potential target for future study. And while weight loss may mitigate complications for elective surgery, bariatric surgery should be considered to put patients at risk for being in a malnourished or a malnourished state. In the future, we might see more of these medical weight loss strategies utilized to help manage obesity in patients, especially undergoing elective orthopedic procedures. I welcome any questions that you guys may have.
I guess I'm confused because I heard a radio interview with an advocate that was talking about healthy obesity. And you didn't really talk about it.
I think something that we don't always appreciate and something that's like underrepresented in the literature is that, you know, BMI is just like a overall assessment of someone's weight to their height. It doesn't really reflect at all someone's body composition, which is likely more significant in contributing to kind of their physiologic state. Certainly when it comes to inflammation within the body, I think the studies on adiponectin show that the anti-inflammatory contribution of skeletal muscle and like this lean fat may be protective against some of the things that we see in patients who are obese.
Anybody can add one comment to that. It's also about the fat storage. We have different storage of fat, including more pro-inflammatory visceral to less inflammatory septic. I think that's the kind of healthy obesity. And we also use a little bit different profiles of cytokines.
Is that where they're anatomically distributed?
Yeah. The visceral is kind of, you know, around heart, liver, kidneys, and they're more inflammatory. Those versus subcutaneous is the one which is known to produce less inflammatory factors.
A couple of years ago, AAOS had a statement that orthos should own the little. Do you have a catchphrase for this? And then also from a pediatric standpoint, it seems like a lot of this problem has started in the teens. Did they talk about interventions at younger ages?
I didn't read any literature on interventions in younger ages, but it's true that someone's body composition, especially while they're going through adolescence and reaching skeletal maturity, seems to significantly impact, like, for example, their peak bone mass, their cartilage thickness. And so I think, you know, intervening on patients, you know, young patients, children that are showing signs of developing obesity is important, not just for, you know, the immediate pathologies that we see in adolescence, but also to protect the health of their musculoskeletal system down the road. I think those clinics that they have at, like primaries for like healthy weight management or, weight loss in children is really one of the most important preventative strategies for kids who are identified as being at risk for obesity.
I also, I'm sorry.
Good.
Can I just answer?
Good.
The most important thing you can say for just parent behavior is no certain parents. And I don't know how many programs that parents do. They have weight loss class. Yeah. On the lesson clinic, which is like where a lot of weight loss is for a while.
I feel like it's become popular that obesity is not just the caloric intake to what your like metabolic rate is, like you said, but obesity continues to go up and up and up. And do they say why it's going up if it's not just caloric intake, and why are there more obese people out there if it's not that?
I think one of the leading ideas is that there's a lot of epigenetic changes that happen for parents who are obese, for example. So when you have a child, if you're obese, then they're higher risk for developing obesity, even if they, aren't exhibiting behavioral patterns that might put them at risk. So there's methylation changes that occur on the DNA that change gene expression over their lifetime. There's also one study I read that suggested that people who are overweight or obese are more prone to marrying someone who's also overweight or obese, so it further propagates the issue. And then also obese women tend to have more children. I don't know if that's a little bit confounded because as you have more pregnancies, you tend to gain weight, but.
So it seems like all of these, I don't know if we call them organ systems or tissues in the limb are maybe all important, right? Like maybe you were talking about how muscle, or somebody was talking about how muscle is so important a few weeks ago, and now you're telling us how fat is so important. And we know that at some level, leptin especially has to do with the nervous system. And so what can we do differently about the nervous system, the peripheral nervous system, to impact these things?
Yeah, so the mechanism that I kind of put up there briefly for how leptin causes these effects is that it leads to stimulation of some of those adrenergic beta 2 receptors on the skeletal system. So, one of the studies I looked at using the Medicare database was looking at the effects of propranolol. And for that study, we weren't necessarily looking at some of these other outcomes. We were just looking at fracture union, but it might be one of the potential things that we can, intervene upon. I think all of these things are very difficult just because of the broad extent to which the sympathetic nervous system, the modulation of that affects whole body physiology. Certainly taking propranolol decreases your blood pressure, decreases the hydrostatic effect within bones, so it also might, decrease some of that mechanical stimulation that's, part of our understanding of Wolff's law and bone remodeling as well.